Hi, everyone. Good morning. I'm Peter Poulos. I'm a middle-aged white man with brown hair and blue eyes, and I'm wearing a blue sport coat and a white shirt. I'm a clinical associate professor of radiology at Stanford University, and I'm the founder and co-chair of the Stanford Medicine Alliance for Disability Inclusion and Equity, or SMADI. I wanted to personally welcome you to our 5th annual conference in disability in healthcare and medicine, hosted by SMADI and MSDCI. It's remarkable to think that in 2020, what was intended to be a small gathering of around 100 participants today has expanded into an international assembly of over 1,000 people from 46 countries. And whether you're joining us from down the street or around the globe, we are thrilled to have you with us. I want to express my heartfelt thanks to our organizers, presenters, moderators, funders, sponsors, and translators, without whom this event would not be possible. Your contributions are the backbone of this conference and a testament to the collaborative spirit of this community. We also want to thank the Stanford Radiology Department, the School of Medicine Office of Faculty Development and Diversity, and the Stanford Healthcare Office of DEI for their funding and gracious sponsorship. We'll be displaying other conference funders and sponsor logos throughout. You can see those on the bottom of the live stream. As we continue, please take advantage of the opportunities to earn continuing medical education credits, which we'll detail at breaks and between the sessions. We've also integrated Slido on our live stream page, allowing you to ask questions, share comments, and facilitate meaningful exchanges. So I encourage you all to make the most of that. Let us all commit to civility and respect in our discussions and interactions. Remember, our community is diverse, not only in backgrounds, but also in experiences, perspectives, and language on disability. Please treat everyone with grace and assume good intentions. This approach will foster a supportive environment where we can all feel welcome, valued, and safe. Finally, I hope that this conference inspires each of you to take action toward improving disability inclusion in healthcare and medicine. There's much reason to hope. The landscape is so much richer in 2024 than in 2020, thanks to the tireless work of many of you presenting and tuning in today. We have a deeper and wider network, scholarly presence, resources, and testimonials than ever before. But we still have a long way to go. Your participation here is just the beginning. So thank you again for joining us, and let's make this 5th year our best yet. I'm going to turn it over now to Zainab Dhanani.
Thank you, Dr. Poulos. Good morning, everyone. My name is Zainab Dhanani. I am a South Asian woman in my late 20s wearing a red dress with white flowers. I'm a medical student at Stanford and the board chair for the national nonprofit organization Medical Students with Disability and Chronic Illness, and the founder of the Stanford Conference on Disability in Healthcare and Medicine. This conference was founded with the mission of advancing the conversation around disability in healthcare from providers to trainees to patients, and this year marking the 5th year of hosting this conference, we are very excited for all of you to be here with us today. There's so much progress to make, and everyone today is an important part of moving the needle forward. I want to echo Dr. Poulos in thanking all of the sponsors, the speakers, and you all as the participants who are taking part in today's work and being part of this movement to continue to bring disability inclusion further in medical education and in healthcare. Thank you all.
Hi, everyone. I am Bonnie Sweenor, the founder and director of the Johns Hopkins Disability Health Research Center. My visual description is that I am a middle-aged white woman with shoulder-length blonde hair, wearing a dark top, sitting in my home office this morning. I first want to thank the organizers of this amazing conference that has been so impactful and so important. I'm truly grateful for the opportunity to give the presentation to you all this morning. With that, I will share my slides. which of course now is not working. Okay. Okay, so this morning, I am going to be talking about dismantling the roadblocks to health equity for people with disabilities. The conversations around health equity have certainly increased over the past many years, but have not always centered on including people with disabilities. So when we talk about health equity, we often focus on the equity part of that conversation. I'm sure many of you have attended lectures and conversations where there's much discussion around the definition of what equity means and how it's different from terms like equality. But what we don't often focus enough on are conversations of health. What does that word mean in the phrase health equity? This is particularly important for people with disabilities because in society there is an inherent hierarchy to how we conceptualize health, where disabled people are viewed at the bottom of that ranking because disability too often is viewed as the opposite of health. We don't think enough in conversations of health equity about the implications of the hierarchy of health, particularly for disabled people, and we need to start having those hard conversations in order to dismantle the roadblocks to health equity, not just for people with disabilities, but for all of us. And this really is so important because people with disabilities are a large percentage of our population and face deep and unaddressed disparities in health. What I'm showing on this slide is a landmark paper from Gloria Cron and colleagues, which is simple yet elegant in showing how people with disabilities face health disparities. A higher percentage of disabled people are smokers, are not engaging in physical activity, have cardiovascular disease, are obese, are not receiving the medical care they need due to cost, and women with disabilities are not up to date on mammograms and pap tests, a higher percentage than women without disabilities. Additionally, there's disparities in the social determinants or social drivers of health for people with disabilities, which is important when we're talking about health equity. What I'm showing on this slide are bar graphs of some of that data from my center, showing a higher percentage of disabled people have less than a high school education, have a low household income of below $25,000 per year, and are unemployed. But it's also important when we are examining these components or these drivers of health, as well as health outcomes, to look at them through a lens of intersectionality. And so when we further expand or stratify those data across racial and ethnic groups, what we find is that a higher percentage of people with disabilities who are from racial and ethnic minority groups are facing disparities across social drivers of health and across health inequities. What this means is that it is important to examine health inequities through a more inclusive approach, to consider the racial barriers, to consider the barriers that people with disabilities face, and think about holistically how we can advance health equity for people who face multiple forms of marginalization and oppression. So at my center, the Disability Health Research Center at Johns Hopkins, we are invested in advancing health equity for people with disabilities, and our tagline is shifting the paradigm from living with a disability to thriving with a disability. We are focused on using data to advance that cause. And as a person with a disability myself, this certainly is both professionally and personally meaningful. And through the work that we do, we are very focused on not just addressing the inequities that disabled people face, but addressing the root causes of those inequities to try and prevent them from even starting in the first place. And those root causes are ableism and inaccessibility, or gaps in accessibility. Ableism, as I'm sure as most people in the audience know, is a threat to health equity, not just for disabled people, but for everyone. And what I'm showing on this slide is a definition, and there's many definitions of ableism, that's taken from an article by Amanda Morris, who covers the disability beat in the Washington Post. And it says, ableism is rooted in the assumption that non-disabled people are the ideal. As health professionals, as public health professionals, and as researchers, that is what we are taught. That is the hierarchy of health, that non-disabled people are an ideal health state. That's exactly what we need to challenge to advance health equity. This matters for healthcare settings as well. And this is data that hopefully all of you have now seen by the amazing Lisa Iazzoni at Harvard. This is a great slide from Kara Ayers' group at University of Cincinnati, really intending to display this data. And Lisa Iazzoni's work showed that 82% of physicians reported that they believed that that people with significant disabilities have a worse quality of life than non-disabled people. And that is a challenging misperception that is so deeply embedded in many aspects of healthcare, research, and public health. Additionally, in this survey, 40% of physicians reported that they were very confident about their ability to provide the same quality of care to patients with disabilities as those without, less than half. And only 56% strongly agreed that they would welcome patients with disabilities into their practice. These data are really indicative of the ableism that is embedded across the healthcare system and the ways in which it plays out in the misperceptions of disability. The other root cause of health inequities impacting people with disabilities are barriers in accessibility. Accessibility is commonly viewed as within a physical environment, but it's far beyond that. Barriers to accessibility come in the forms of barriers in information, in interactions, in services, in programs, facilities, as well as the physical environment. And to get to true access, we have to have equivalent ease of use, which means it can't take someone with a disability five times as long to do an activity as someone without. That's not even close to equivalent ease of use. It's important for everyone to understand that accessibility is all of our responsibility and should not just be on the backs of people with disabilities. That really is a shift that has yet to take hold in healthcare and in public health. Again, another example from Lisa Iazzoni and her colleagues. This was a paper by Tara Legoo at Northwestern. In addition to the quantitative research that Lisa and her team have done, Tara Legoo led some qualitative research examining the ways in which physicians view people with disabilities. This work got a lot of attention and was featured in the New York Times, and I'm showing a snapshot of that with a picture of Lisa, who's a power chair user, on the front. And a quote from that article says, "Some doctors said their office scales could not accommodate wheelchairs, so they told patients to go to a supermarket, a grain elevator, a cattle processing plant, or a zoo to be weighed." That's both gaps in accessibility and ableism. Imagine being told to go to a zoo to be weighed, weight which is something so important that it is captured at every single healthcare encounter. We have a lot of work to do. But in addition to these root causes of health inequities, we have to think about data. At my center, we talk about who counts. Depends on who is counted. This is a paper that I wrote with the amazing Lisa Meeks and Nick Reed. And the point of this statement is that we have deep and pervasive gaps in disability data that have resulted in the inability to identify and change the health inequities that people with disabilities face. Unlike race, ethnicity, and gender, and age, disability data are not routinely collected as part of demographic information. That erases the opportunities to make change, to really take head on the health inequities that we know are happening in our communities. This issue has been elevated recently in some discourse with the US Census Bureau. So the Census Bureau had proposed changing the ways in which disability was going to be measured. Those changes would have resulted in a drastic undercounting of people with disabilities in the United States by about 40%. That's alarming because those changes were being pushed forward without engaging the disability community. But underneath that, the issue is a need to shift the viewpoint and viewing disability as a health outcome to recognizing that disability is a demographic group. We are a group of people, a diverse group of people that have shared experiences and face unique barriers. The ways in which we capture data needs to reflect the experiences we have and the ways in which we view ourselves. In order to achieve health equity and to change that hierarchy of health, we also have to change the way in which we collect and use disability data. Additionally, data are so important for changing the ways we can make change. Without data, we are stuck in a reactive approach. We can't be proactive. What that means is without data, the only ways to change are complaints and lawsuits filed by disabled people. That means that equity and justice are also on the backs of disabled people. Data can change that. Data can create infrastructures to identify where and when things are not working and to do something about it before it impacts a large number of disabled people or requires the inequitable process of filing complaints and lawsuits. So this process that we use at my center is called Disability Data Justice. It's all about using data to uphold and advance equity and justice for disabled people, including health equity. This is a process where disabled people are involved at every single step and action at all levels. The overall summary of the process is it starts with expanding and improving data collection, data access, and data use. We believe we don't own the data. The data belong to the disability community. We then use that data and evidence to drive policy change. We use the data as an evidence base. And then we use those policy changes to support wide systemic changes that intend to improve and expand equity and accessibility for disabled people. We then use data again to uphold structures of accountability. We're using data to evaluate and improve policies to see where and when things are working and where and when they aren't. These structures don't often exist, unfortunately. In part, it is because of ableism, it is because of gaps in accessibility, and it is because of gaps in data. Examples of the ways in which we are putting disability data justice in action are our disability data dashboards, and I'm showing just 3 examples on the slide. We've created dashboards around COVID-19 vaccine registration to assess how accessible those processes were to register for vaccine during COVID-19. We have a dashboard around enrollment in SNAP, or the Supplemental Nutrition Assistance Program, how accessible and disability inclusive that process is, as well as a dashboard on public transit. We also have others, and you can learn more, interact with the data, download it, and use it yourself on our website, disabilityhealth.jhu.edu. But in addition to making change in data, we also need policy change. And as was indicated in the introduction by Pete, there has been good change and traction in the past few years. What I'm showing on this slide are the lists of the committee members on the National Institute of Health, Advisory Committee to the Director, Working Group on Diversity, Subgroup on Individuals with Disabilities. I know that is a very long name, for which I had the honor of co-chairing along with Lisa Iazzoni and Steve Barnett. This amazing committee, the majority of whom were people who identified as having a disability, had the opportunity to provide and create recommendations to the NIH on how to make NIH more disability inclusive in the research that they're doing and in the people that they're supporting. We released our recommendations in December 2022, and they were unanimously endorsed. It was then, or is now, up to NIH leadership to put them into action. Not too long after our recommendations were released, staff members and leadership from NIH wrote a blog post in Health Affairs titled "Ableism in Biomedical and Behavioral Research at NIH." An important quote from that article says, "There's space to address both disease-focused research and the health of people with disabilities broadly." I highlight this because this is all about addressing that hierarchy of health that is needed to be addressed in order to advance health equity. We can do both things. We can do work that is disease-focused, as well as invest in and advance the health of people with disabilities. An important outcome so far of the working group has been pushing for NIH to designate people with disabilities as what's called a health disparity population. This has been so important for advancing health equity because without this designation, we didn't have opportunities for funding for research, advancing health equity of disabled people, and including disabled people in that process. But on September 26th, 2023, the NIH made that designation after a bit of fight from many of you and the disability community. I'm showing a snapshot of an article written by Amanda Morris in the Washington Post, who I referenced in the beginning, really covering that story and a bit of the fight that we had to put up to get there. I'm really grateful for this change, which really has been important and impactful. But let me be clear, this work is so far from over. We have a lot of work to do. I hope that all of you will join that fight. This is certainly a time where issues of equity have become divisive and challenging. But people with disabilities are part of all of our communities. And so disability has an opportunity to unite us. Disability is a diverse and rich community and population of people, and we have to honor and embrace that. But we also have to recognize that disability issues, and including people with disabilities, is a critical component of advancing health equity. And I am so thankful for the work that all of you are doing to move us forward. And if you want to learn more about my center or about the Disability Health Research Center, I'm going to give one last plug for our website, disabilityhealth.jhu.edu, and also for the Disability Health Equity Research Network, which Scott Landis at Syracuse University and I have established. Really, it's Scott who's doing the great work. And welcome anyone to join. We meet virtually, and for anyone that wants to learn more about ways in which you can get involved in advancing health equity for people with disabilities, we welcome you. I'm so grateful for this opportunity and this exciting conference. Thank you all.
Thank you so much, Bonnie. That was amazing. I'm going to do a backwards introduction since we had a little bit of a non-smooth transition. That was Bonnie Sweener, and she gave our distinguished keynote presentation for this year's conference. And thank you, Bonnie, for putting this into perspective for us and framing this from the 30,000-foot view. Thank you for all the work that you've been doing. We all appreciate you very much.